My specialty is liver, pancreas, and gallbladder. I do a lot of patients with pancreatic cancer. Looking at the literature, I suddenly realized the incidence of GIST is pretty similar to pancreatic cancer in this country. So I'm not going to repeat what Ian Judson already mentioned on the forefront of chemotherapy in management of GIST, but I will touch a lot of my topic on recent advances in surgery, especially in relation to GIST in pancreas as well as in liver. I'm going to just talk a little bit on the background of GIST. Probably you can tell me more. So surgery for, I'd like just talk a little bit about surgery for GIST, especially for primary disease. I do operate on people with primary GIST tumor, mainly in relation to duodenum. I'll show you a video. And duodenal GIST, which is a very difficult place to operate, and also mainly on metastatic disease, because as you probably already know that liver and peritoneum are the common site for metastatic GIST tumor. So as I said, it's pretty similar to pancreatic cancer, 5,000 to 7,000, 6,000 new cases each year, and tend to occur in the middle age. And unfortunately, we are very preponderant to GIST male, and can occur in any part of GI tract. And commonly occurring in stomach, and can occur in small bowel, large bowel, anywhere in the GI tract, essentially. Symptoms, probably some of you are patients, probably can tell me more, and sometimes very non-specific. Discomfort in the abdomen, abdominal pain associated with some GI symptoms, constipation, diarrhea. And if you're lucky enough to have a good GP, and he will send you to have a further investigation with endoscopy, either upper GI endoscopy, and pick up a small tumor, especially those tumors less than 5 centimeters. We now know that they do much better if tumors are very small than have intervention much early. So this slide just shows that the size is absolutely important in terms of prognosis of and survival in patients with GIST. So if you look at the size itself, if it's less than 5 centimeters, over 60% of people will survive more than 5 years. If you look at the size over 10 centimeters, the survival rate was much lower. So surgical management of primary GIST, I'm a surgeon. I always tell people that the best treatment remains to be surgery, and unfortunately it remains true for most of the cancers simply because the chemotherapy at the moment, although there are a large number of chemotherapies to some rare type of cancer that are not terribly effective, but in the GIST tumor is quite different. So, but if somebody comes with primary resectable tumor in any part of the GI tract, I would say surgery first. And the surgery, what type of surgery, depends the size of the tumor. And now we are actually heading away from radical surgery, like Judith just told me that somebody with small GIST in the stomach, and one of the surgeons recommended total gastrectomy. I think that is out. So we try to minimize the damage to the patient, to do as little surgery as possible, but to achieve the same oncological benefit and effect. That means we try to completely remove the tumor, excuse me, try to do R0 resection. That means when we look at the tissue, we know the tumor completely removed with a clear resection margin. That means we leave a little bit healthy and normal tissue behind. And when my histopathologist looking at the specimen we sent after resection, he will tell me that the margin was completely clear. That means tumor is well away from the place where I took the tissue. So that's R0 resection. So it's very important to achieve R0 resection. We know that in most of cancer cases, if we can achieve R0 resection, the survival is automatically better because the chance for them to have a local recurrence or systemic recurrence is much lower than people who had R1 resection or R2 resection. R1 resection means when surgeons, when we do the resection, we say, okay, it's clear, tumor is away from the resection margin, but pathologist comes back and says, sorry, it involves margin less than 2 millimeters. R2 resection means we simply cut through the tumor, but I think nobody would recommend R2 resection in this modern age. So methods of surgery for primary GIST tumor, we can either do a laparotomy, that means open somebody's tummy up, have a look entire GI tract. The advantage for that is we can do a thorough exploration of peritoneum. Peritoneum is lining of the abdominal wall and the liver and its surrounding structures, see how extensive we can do resection. And the other advantage is we can do a quite extensive unblocked dissection of surrounding lymph nodes and the tissue to complete the resection. On the other hand, laparoscopy is very minimally invasive. We can do it with a very small cut, normally around about 12 millimeter, between 5 or 12 millimeter, and then put instrument in, resect the tumor. The advantage of that is patient can recover very quickly, but length of surgery tends to be much longer than open resection. But patient recovery is much quicker. Post-operative analgesia, painkiller requirement is much low. So if it's a small tumor, we tend to offer patients laparoscopic surgery rather than laparotomy. The other thing is we have to bear in mind we are dealing with cancer, so even with laparoscopic approach, we try to achieve same oncological result as we do laparotomy. That means try to achieve R0 resection, prevent the tumor spreading. When the tissue is removed, we try to put it in the tissue bag so it doesn't cause contamination or spread of tumor when we actually take the tissue out after resection. Now I'm going to just talk to you a couple of cases I personally dealt with. Somebody very young, 2 young patients came in with diagnosis of duodenal GIST. For duodenal GIST, unfortunately, the location of the tumor is such that we have to offer bigger operation because anatomical location of the tumor. If you look at the picture on the left-hand side, that curve, like C-shaped structure, that's duodenum. Inside there, you will find the head of pancreas and bottom part of the bile duct, as well as a big blue structure, that's vein called portal vein. That's important vein supplying the blood, draining all the blood from GI tract into the liver. So we cannot afford to damage that vein. On the other side, the red structure, that is superior mesenteric artery, that gives all the blood supply to the small intestine and part of large intestine. So it's a very tricky position to resect. I'll show you the next case. So this procedure we call pancreatic duodenectomy is a very radical, very big operation, originally described by Alan Whipple. That's why the operation is named after him. He described in 1963. It described only 4 cases. I think all the patients died, and you can see how much we advanced over the last few decades. And he actually did this operation as 2 stages. So first stage, he removed the tumor. He didn't actually put everything together. So everything is like the gallbladder is cut halfway, and the stomach is cut, and duodenum is completely chopped. And then he put the drains into the abdomen, and a week or 2 weeks later, if patient is lucky enough to survive the operation, he would go back in to join patients up. So not surprisingly, all the patients died from this. His mortality was very high. Nevertheless, I think this operation is a sort of a standard surgery for duodenal pancreas and bottom part of the bile duct. The mortality at the moment now is much lower, around about 5%. So this is a case I had, a 45-year-old lady with diagnosis of duodenal GIST. So that's superior mesenteric vein, SMA, and tumor is there, highly enhancing in the second part of duodenum involving the ampulla. Ampulla is a structure just at the opening of the bile duct, and when the pancreatic duct comes out, join onto the bile duct. So this is an intraoperative picture. You can see that's pancreas. And then the pancreas is divided, it's tunneled on top of that blue structure, portal vein, superior mesenteric vein, then is divided. In this procedure, I tried to modify, because I know it's a GIST, I tried to minimize the resection field. So I actually did preserved her duodenum. Okay, I didn't take all of her duodenum, preserved the duodenum and removed as little as I could the head of the pancreas to preserve most part of the pancreatic function. Pancreas has two functions, so that is the duodenum. I removed a bit of head of pancreas. So to preserve the duodenum, I clamped the bottom part of the pancreas, and I just divided the duodenum at the same level of those two clamps. Otherwise, for standard operation, I had to remove all the duodenums from the left side and deliver all the duodenum onto this side and take entire duodenum. Technically, it's a very radical surgery for GIST. So it is a limited resection for duodenum by preserving most part of duodenum, 2/3 of duodenum, just removing at the level of the tumor with a bit of head of pancreas. So that's how the duodenum is mobilized, and then the duodenum divided by preserving at least 2/3 of duodenum. So finally, a bit of pancreas attached to the vein is removed with, we call the ligature, essentially diathermia machine, which cuts tissue and also stop bleeding at the same time. So that blue structure, that's a sucker. The blue vein is on the right-hand side. The pancreatic stump is on the other side, and the pancreas has two functions. One is to produce digestive enzymes, the other one is to produce insulin. So ideally, one shouldn't remove too much pancreas. So this is tissue removed with the tumor. Very limited resection of second part of duodenum by preserving. There are 4 parts of duodenum by preserving first part, third and fourth part of duodenum. So that's the resection bed, that's the portal vein. And then we have to put everything together. I can't do 2-stage operation these days. So I put the stomach, pancreas onto the back of the stomach, because if somebody has normal pancreas, it's very soft. It's very difficult to join pancreas onto any other structures, because the tube inside the pancreas, we call the pancreatic duct, is very fine, very small. It's very difficult to form anesmosis. So this technique is to reduce post-operative problems like a leak from the joint, bleeding from the pancreas, and also as a result, a high mortality related to leak from the pancreatic joint. So that operation took about 3 hours to complete, and then the patient is still well after 4 years. There's no disease, recurrent disease. She's very lucky. She had a low-grade GIST, very low mitotic index.